So, welcome to week 5. It's going by really, really quick. I do suggest some of you have, some of you haven't. When you can, start looking at your pediatric assessment assignment. Send your papers in or do the assessment portion. I'll look at them, send them back. And it also helps you to think as we're going along into these new type of conditions, diagnoses, because children got these weird things that they do, and you'll see that as we continue. So this week you have your discussion question, and you do have a CJ Sims. I noticed that all the CJ Sims that people had trouble with, now they're being sent in properly. So and I did score all of them, and everybody got 100. Everybody did well on them, so that's a good thing. So cardiac respiratory, they work together, and they're universal also to the adult world. So let me go and start and try to help you understand things that you need to know regarding this. I worked in a cardiac intensive care unit for 10 years, and it's my most favorite of all jobs I ever did. Was really neat today. I'm teaching cardiac, and the cardiac surgeon put me as a friend, asked me to be a friend on Facebook. I'm like, oh, Dr. Burke still remembers me. But yeah, I am sort of unforgettable. I ran the night shift for him. All right, so respiratory infections. Respiratory is all about the lungs, but remember, it's all upper airway because that all affects into the lungs, right? So you've got to be careful with that. There is upper, which is the nose and mucus, and the lower, which is usually like your pneumonias. Now, of all of the upper respiratory infections, most of them are viruses. Parents take their children to the doctor, urgent care, ERs. Oh, he's got a big fever, he's got this cough, and they expect antibiotics. And we say, well, it's a virus. And we tell you what, just, care of Tylenols, Motrin, fluids, rest, and that's it because antibiotics don't work with viruses. Now, one of the things that children get is something called RSV, which is respiratory syncytial virus. Now, you notice infants, children, adults. For me and you, it is a common cold. But for infants, think about younger children. They suck, swallow, and breathe, and that's huge. Now, take mucus and put it in the nasal passages, they can't breathe. So now it becomes respiratory distress. They tire out, they don't eat, they don't get nutrition, et cetera, et cetera, et cetera, right? And they do have low fevers with it. Now, we're going to go in further. I'm going to tell you treatment for it. There is a monthly immunization for it, and we do use that for our immunosuppressed children, like a cardiac child or a child born premature that's had respiratory complications through it. So just know RSV is an important subject, and we're going to look at it again. Now, one of the things we need to look at is the immune system. Now, mom gives us a great immune system when we're born, but it does wear off. It goes away, just like your blood cells die. And you're not making blood cells yet till, after 3, 4 months, and then you start making blood cells. But with your antibodies, you're talking about infections and you're talking about getting sick. Well, the first 3 months of life, you should have moms and you shouldn't get sick. Not saying you don't, but I'm just saying it's less chance. Now, around 3 to 6 months, mom's immune system's going away, and now you're starting to get sicker. So it's all about those maternal antibodies just going away. The baby hasn't had a chance to build up anything yet. They haven't been exposed yet. This is why we give immunizations at 2, 4, 6 months, 12 months, 15, 18. I mean, we're giving a lot really quick because we have to build those immune systems. We know that toddlers in preschool what do they do all day long? They swap spit, like I said, right? In daycare, what do? One toy to another toy, joom, joom. Preschoolers, same thing. So they're spreading everything. It's actually a good thing because they're building up immune system. Their antibodies are getting stronger because of how many times they're sick. And by the time they get in school, usually it's just those bacterial infections that they do get. And what I'm basically saying is you get increased immunity with age as you get older. Now, I'll talk a little bit about ears, and we're going to go a little bit more in a couple of slides. The one thing about children and their ears, it's short, it's open, it's straight, and mucus in the nose goes to areas of least resistance, up into the eustachian tubes, up into the ears. And this is why we get these ear infections on these young kids. Now, what do you see when a kid gets sick? Well, all children are different, but you could see pain if they have an ear infection. You could see fever from low to very high. And I'm telling you, usually the high fevers are usually viral. Of course, if they have a meningitis, you might see those signs and symptoms. But what you usually see is the kid stops eating and they sit in a corner or they're laying down and they're just not playing. Those are those signs. You might see vomiting, diarrhea, or their tummy hurts. You might see a cough. Sometimes a young kid sticking their hands down their throat. They're telling you, my throat hurts. And of course, any of the mucus coming out of the nose. And respiratory sounds actually sometimes mimic what's in the upper airway. Children are very hard to look at their lung sounds because we might just listen to referred sounds. So I always listen to the upper airway, the throat, or right over, the notch right here. If it's noisy, probably it's upper airway. Do I suction? Tell them blow their nose. One of those things to clear it. Then I might be able to listen to their lower lungs and really get a feel of exactly what's going on. Our goal is for them to breathe easier, to be able to rest, to be able to eat and drink. And the way that we do that, number one, reduce that temperature. A child can come into the ER, sick, fever, laying there, mommy's lap, don't look good. Give them something for the fever. Because many parents say, well, I need to bring the kid in with a fever to show us that there's a fever. And I'm like, oh, don't ever do that again. They have a fever, please medicate and then bring them in. We believe you. There's no reason why you're going to bring your kid to the doctor or to urgent care or ER just because you want to. So give them that Tylenol, the Motrin. And in like 30 minutes, all of a sudden this kid is up, out, moving around, given something to drink, a popsicle, and they're drinking, they're eating. And that's our goal because those liquids help keep those fevers down, right? Now, otitis media, as I was saying, these short, open, wide eustachian tubes, mucus gets plugged up in there. The biggest thing is pain. Please, you get a kid with an ear pain or holding their head or a little baby tugging at it. You know it's an ear. Please medicate them. Give them either the, acetaminophen, the ibuprofen, whatever they can have. Give it to them. That's your number one priority because antibiotics aren't going to work instantly, right? And that's the pharmacological what we do for them. Now, if they're having chronic ear infections, we want to prevent problems with hearing. So all of that extra pressure, et cetera, could cause, the hearing to decrease. So many times what they'll opt to do is put tubes in. And usually what I've seen is they'll do tonsils, adenoidectomy, and tubes all at the same time as an outpatient procedure. And hopefully this drains the mucus and helps keep it from getting ear infections. Now, mononucleosis is something to do with sore throat. So it's almost like flu-like sore throat with swollen glands. It is a virus. It's a herpes Epstein-Barr virus. Okay, so we know it's acetaminophen, ibuprofen, fluids, bed rest. That's how we treat it. Well, With mono, the kissing disease, benign, right? Well, let me tell you what usually happens. So these children go to the doctor. The doctor does a strep, does a flu, does a culture, and everything's negative, negative, negative. Oh, it's a viral pharyngitis. Sends them home. 3 days later, they call the doctor again and say, I'm sorry, he's still sick, still has a fever, still looks miserable, throat still hurts, and they order an antibiotic. 3 days later, they're still sick. That's usually when they go to the ER. And we go with those symptoms, sore throat, fatigue, fevers, and we're seeing swollen lymph nodes, neck, armpits, even the spleen and liver get enlarged. We will do, um, again, we'll test for strep, of course, or the flu, but we're going to do what we call a monospot test. We're doing blood, and we'll do a CBC with that. Well, the CBC is going to look for a white count. If you have a bacterial infection, white count will be elevated. Well, with a virus, it's not. Well, usually white counts are fine. Monospot tests positive. Well, how do we treat infectious mononucleosis? The biggest problem and the biggest concern is the swollen lymph nodes, especially the spleen or the liver. It's like it gets swollen like a balloon. And if too much pressure is pushed on the abdomen, it will burst. I had a 9-year-old boy came in on a Saturday morning with his father. We went over, please, no contact sports, protect the abdomen. You must go back to your doctor in 3 weeks to get permission to do PE in school, et cetera, et cetera. Tell the other brother in the house, no roughhousing, protect that abdomen. We really told him it could burst and that could be life threatening. 1 week later, on a Saturday, I'm primary trauma nurse. We get a copter call from rescue. It's a boy out on an ATV in Homestead in the Everglades, which is what they do. Fell off, fell on his abdomen, and he came in and he was dead on arrival. It was this kid who had mono, and the father let him out on a trike. I taught them, and the physician he had taught him exactly the same thing. And I'll never forget that little boy. And it was hard, as nurses, I was, I had to run out and cry somewhere because, I knew the child. So, big thing about infectious mononucleosis is avoiding contact sports and protecting that abdomen for the first 3 weeks of it, and then they have to get approval from their pediatrician to be able to go back to what they're doing. Now, bronchitis, also called tracheobronchitis, the tracheus and the bronchus get swollen. All right. It is this thing that usually there's no fever, but it's non-productive cough, it's dry, and then try to go to sleep at night. You can't. You're coughing and coughing and coughing. They usually ordered, like you'll take acetaminophen or ibuprofen because you hurt from coughing so hard. Maybe you have a humidifier at the bedside, and then they'll give you cough suppressants. But it is a dry, hacking cough, not productive, and it's worse at night when you try to sleep. Now, croup is like bronchitis, but a little different. What happens with the croup is the larynx, the trachea, and the bronchus gets inflamed. And what happens is it swells up, and you can get air in. The air going in has to go over this larynx and bronchus. They're all swollen. So there is an inspiratory stridor. It's hard to get air in. It's a sort of sound, trying to get it in. All right. And the other thing with it, when they cough, it is the most distinctive cough. It sounds like a seal barking, barking cough. You can tell a child with croup from across, a whole ER because it's that distinctive. Laryngotracheobronchitis, same thing. It's a group. And usually they're viruses. Usually these are not a bacterial, and we treat them with a steroid. So usually before it, you might have had some sort of upper respiratory, type of thing, but it's that inspiratory stridor. And because you're having difficulty getting the air in, you're going to see retractions. And of course, you're going to have that horrible cough that you can hear. And if we do not treat it, it gets more and more swollen. And the treatment is humidification and steroids. And if we don't get it from, stopping, it gets bigger and bigger, and it could cause the respiratory failure and acute epiglottitis. Now, the epiglottis is that leaf-like structure that covers your trachea when you swallow food, so you don't aspirate, okay? Well, can you imagine this thing that's protecting you swells up and covers the trachea? How are you going to breathe, right? That's, the big thing with it. So as you try to breathe, you're going to see this child cannot swallow. You're going to see drooling. You're going to see their throat hurts. They can't swallow. Their voice is muffled. It's like frog-like, they call it. And absence of a spontaneous cough. They're not coughing. Again, inspiratory stridor. These children usually are leaning forward in that tripod, looking for a place where they could put themselves to get that little piece of air in there that they can. Now, epiglottitis is emergency, high level, high alert, and your job as a nurse is to make sure that get the kid into a room and make sure you have an intubation or a tracheostomy tray at bedside. A lot of these kids might need intubation if we don't treat them quick. What do we do? How do we treat these children? You get this child in, get them wherever they sit, wherever they're comfortable, let them be. If they're sitting in a wheelchair and they feel good, don't touch it. They can get on the stretcher, fine. But I mean, this is how serious it is. So we're going to start an IV usually, these kids, because they can't breathe. You always do hydration, but you need to give steroids too. So we need that there. We're going to put them on some nebulized mist and some oxygen. And what we do, first of all, is an aerosol with racemic epi. So that epinephrine goes right down into that epiglottis and stops that swelling. So your job is to get that kid in some position where they can breathe, get that racemic epi in, get the IV in so that we give steroids. And these kids, I've never seen them intubated, but I'm pretty quick when I see them. I'm like, get an IV, I'm getting racemic. And it's like we're moving like in a team, and these children, can turn around really quick. Now, I said I told you a little bit more about RSV. The other name, and they're used synonymously, whether it's RSV or bronchiolitis. So it's like the inflammation of the bronchioles, right? So it is from winter to early spring in those areas that have seasons. A little different here in Florida, but that's what it is. Now, those children, like I said, that are immunosuppressed need protection because to suck, swallow, and breathe is hard enough. Put that mucus in their nose and they can't breathe. And we want to prevent that as much as we can. So we give this immunization monthly, and it's called Synagis or palvizumab. And that mAb is one of those antivirals, and that's what we give. Now, children a lot of times need to get a tonsillectomy, right? They're snoring or part of the ENT and the ears things, and they do it. Now, when you get a child back from a tonsillectomy, We need to teach them, because usually they go home right after this. We need to teach them that they shouldn't have any foods that's going to irritate. What they do is they cut the tonsils out, and usually the adenoids or whatever, and they cauterize these scabs that are left, like big scabs in the back of their throat. So we don't want to do anything to irritate it. I mean, orange juice, any citrus juice, absolutely not. Any highly seasoned foods, you're not going to gargle, you're not going to vigorous toothbrush, you're going to do none of that. Younger kids keeping things out of their mouth and making sure they're not clearing their throat, coughing. Older kids, I mean, younger kids don't like it, but you give them ice, and it's ice collar, and you put it on and it helps. But some of the younger kids, it's too cold, it's too cold. So when you can, you do. Acetaminophen is all you need now, really, for pain. It used to be a lot more, but we were overdosing our kids, believe it or not. So we don't use them anymore. And these kids need to rest. They need to relax. They don't need to be up moving around because of those scabs. We don't want them to fall off. And ears hurt a lot after the surgery, whether or not they've done the tubes. So we chew gum. We chew gum a lot. And that's like going up in an airplane and you pop your ears, okay? Now, one of the things that we need to teach is some of these complications that can occur. So if you're smelling their breath, like, and there's a fever, it's normal to have it. But if it persists, it needs to be attended to, go back to the doctor. And of course, any of those earaches that we just can't make feel better. And usually within 1 to 2 weeks, they can go back to activity normal. I saw one girl came in, she was like 7 or 8, and she had just gone to the ENT doctor. She had just had tonsillectomy. And she was going home and she vomited a big clots of blood in the car. So they turned around and came right to my hospital. When she came in, she was vomiting. So we handed her one of those big pink buckets, right, for those basins. She filled it halfway up. She went to hemovolemic shock. I picked her up. I ran her back to the trauma room. I had somebody to come. I said, I need IV star to help me. We got it in and we poured a 7-year-old 1,000 mLs of normal saline. When we first started and hooked her up to the monitor, her heart rate, now this is a 7-year-old, was 180. Her blood pressure was 70/40. So she was in shock. So, and she was looking pale. So we got the fluids back, we got ENT in, we sent her up to the OR and they recauterized her throat. So tonsillectomies are something that we really need to teach our parents about and what to do, right? Pneumonias, we know there's all different types. We know it's a consolidation in the lung somewhere for some reason. Could be bacterial or it could be viral. Many times they are viral and we just treat symptomatically. Acetaminophen, ibuprofen, liquids, right? Viral. Most of the time, we think they're bacterial or it could be mycoplasmal. And the one thing we do have today is that vaccine. So it'd be one of those questions I would ask, are your immunizations up to date, right? Have they had that vaccine? So you know what you're prepared for. Now, pertussis is one of the immunizations, right? I seen one break out down here. There was 5 cases. The problem with pertussis is all airborne and it's extremely contagious. And it's because there are some children whose parents don't want them immunized for whatever their reason is. I mean, it's their choice, but those children who've been immunized still can get them sick. So this is something that we need to know. And treatment is zithromycin and respiratory isolation. Now, my grandson just last week, swallowed a quarter. And my daughter-in-law calls me up, said he had it in his mouth and he started horse playing with his mom and he swallowed it. And he was breathing okay. And he felt it. He thought he had gone in. And I just told her, I said, they're going to take an x-ray. If he's breathing okay, usually you just check the stool and watch it come out. If he has increased pain at all, you need to get him for treatment. That means it's stuck. Well, of course, he started having pain in his tummy and it had not dropped down into his stomach yet. It was still at the lower end of his esophagus. So he had to go have an endoscopy and they needed to pull it out. Usually, if it's stuck like this picture here, and they're in the ER, what we do is we call the surgeon. They come, they put a Foley catheter with a big balloon on the end, put it down lower than the quarter, increase that balloon, and then have him sitting on the surgeon's lap, leaning forward, pull it out, and it comes out. And I usually say, if I get it first, it's my quarter. So I have distracted this child. He's on the floor grabbing the quarter before I can get it. He said, it's mine. I got it. So I make this thing, which is difficult. I mean, things coming out of his throat. I made it fun. And I've done that more than once. You monitor them for a little bit, make sure their airway's fine, and they go home. Other things I've seen is French fry at a country club on a 3-year-old got stuck in a throat. Rescue got him here. We couldn't get the French fry out. This child ended up on ECMO, which is like a heart lung machine. We couldn't oxygenate him. And that kid didn't do well. After 5 days, the kid died on a French fry. So aspiration, foreign bodies can be a big thing. All right. Our goal with that aspiration, number one, are they breathing? Do they have an airway? That's always number one. We know aspiration could just be feeding, right? A lot of kids have reflux, GERD, that could be part of it. Teaching them the parents, how to feed these children well, how to burp them well, not overfeed them, sitting them up after they eat. Of course, those things. And then, years ago, Johnson and Johnson baby powder used to smell so good. And I used to love to put it on the baby's little butts, but that powder today, we can't because there is talcum in the air and they do inhale it and it can cause a risk. So we don't believe in powder anymore. Now, a respiratory condition that you're going to see all over the place, ZAMs, SEs, your NCLEX, they love cystic fibrosis. This is an inherited disorder. It's like sickle cell. If mom and dad, both have the trait, it's 25% for these children to have it. Same type of thing. What do you see with cystic fibrosis? Now, many times it's diagnosed at birth. They do not have a stool in the first 2 days of life. And one of the things they test for is cystic fibrosis. When they look at cystic fibrosis, if you told the parent to lick that child's skin, the salt level is extremely high. Like so much salt is lost in the skin. So never ever restrict salt on these children. They can have a salt shaker because it's coming out of every pore. We know cystic fibrosis is not just lungs and phlegm and mucus in the lungs. It also is in the small intestines. It affects the pancreas, and there's problems with digesting food. And these children have a hard time with nutrition and their respiratory status. Okay. You're going to have the odorous, foul smelling, oily, greasy stools is what you're going to see in these children. And because they're losing nutrition, they're not going to have the weight gain like a normal child, right? And then we have this respiratory condition that we really have to work on. So we're going to do a sweat test. We're going to confirm the diagnosis. They just put probes on and measure sodium. It's basically what they do, believe it or not. The treatment, now, Because this mucus in these lungs are almost like a petri dish, and we're always inhaling germs, right? And the germs go onto this petri dish and they grow. They have multiple type of lung infections. A lot of times we give aerolized in the aerosols antibiotics. I think gentamicin aerosols are one of the most popular ones in cystic fibrosis. We're going to have to give some sort of treatment to thin that mucus and make it to the point where we can expectorate it easier. So you're going to have those medicines, those sort of type of aerosols to be given. We know that they're going to have special chest physiotherapy, and we need to give an albuterol aerosol before chest PT so that the lungs are open and they can expectorate and keep those lungs moving, okay? And because of the nutritional deficiency, these children have that pancreatic insufficiency and they are going to be getting what we call pancreatase. It's one of those enzymes that supplement what the body usually produces to help digest food. The things we need to teach our parents. You need to give it immediately before they eat food or snacks. They're little enteric beads, some of them. Of course, we never ever chew, crush those things. This is the one that if there's a little teaspoon of food, you can give it that way. You wouldn't like sprinkle it all over the food because you want to get that in there as they're eating to digest it. There are powders that we use. This is something that we need to make sure that mouth is rinsed because it can affect the teeth. And the thing in pediatrics is these kids are growing, so they're going to need different doses as they get bigger. I mean, they could gain 5 or 6 pounds in a year. Well, we have to remember, let's increase our dose. One of the things with cystic fibrosis and males is
Or
that
as you guys know, title, Alani did pass away.
one of the things about cystic fibrosis is males, it tends to put mucus in their vas deferens ducts, and they do not have the ability to make women pregnant. Women with cystic fibrosis can be pregnant. Okay. Yes, it's a higher risk, but they can be. Males, if they do a bilateral lung transplant, 1 year later, he will be able to, have a baby with his significant other. So that is significant with cystic fibrosis. Also know that if you have cystic fibrosis, it affects the pancreas. So guess what? Higher risk for diabetes. So it's something that needs to be watched closely. Now, acute respiratory distress syndrome is when something has shocked your lungs. It could be infection, trauma, drug overdose, and near drownings. You're like inhaled all that water, so you've been hypoxic. So all of those things can. In children, we know one of the highest things that cause problems is sepsis, infections. Children don't handle infections very well. Children with ARDS are sicker than sick. These are your ones that require intense care. All of that machinery there, that is ECMO. And what it does, it pulls blood off, it oxygenates it and puts it back in. It doesn't work as a heart, it only works as a lung. But still, with all of this, a lot of these children don't make it. Always review your CPR. They're putting CPR questions into the exams, but also remember that in a life saving event with children, there's parents involved. Make sure, if at all possible, we keep these children with their parents. It would be hard. I don't know how even me having a child going under CPR that dies that I wasn't there holding their hand. So these things are important. Now, not all the time can they be there. So have one person with that parent, keeping them in contact to what's going on, because this is a very difficult time. Asthma is one of the most common of all conditions. You talk respiratory, some of you have asthma, children have asthma, or you know somebody with asthma. It is a hyper responsiveness, some antigen in the air, whatever, causes the lungs to go into spasm. Now, children with asthma, what we need to do is a pulmonary function test when they're well, when their lungs are working good, to see what their capabilities are on that pulmonary function. Also, to do skin testing. What are they allergic to? Is it cats, dogs, grass? Is it, the fall leaves that fall everywhere, that cause these asthma attacks? And then we know if this is what they're allergic to, let's avoid it. I mean, if you're allergic to grass, I think playing soccer or baseball wouldn't be the best choice. Maybe go be on the swim team, right? That's something where the allergens would be less. So this is, what we need to help our parents and our child, work with. I mean, we want to, at all chances, any condition on any child, to try to keep them in normal activities, try to keep them healthy. How do we get that child playing or doing what they want to do? Is it making sure we have our little meter dose inhaler? Maybe it's doing a treatment before we go play. What is it that we can prevent it? With asthma, there's multiple treatments. We do have that morning and evening aerosols that have a little bit of steroids in that prevent bronchospasms. And then we have the rescue, the albuterol, Ventolin, whatever, the name, they're just a bronchodilator. And then in these treatments where the kid starts to wheeze and go into attacks, always corticosteroids that do help decrease the swelling. Now, your heart. First of all, in hearts, it is the flow of blood in the heart. Think of a big garden hose, all right? Just think of that and what happens, and we're going to go from there. Now, children are born congenitally with some amazing heart defects, and it's amazing that they, come out of mom. Some of them we don't know that they have it, and some we do. But getting them treatment and getting them stable to be able to go to surgery is quite amazing. And infants are resilient; they really are. And then there's those acquired infection. Infection causes cardiomyopathies, especially viral infections. Autoimmune could be lupus, right? Or it could be environmental, or it runs in the family. Now, what I want you all to do is I want you to look at the heart and trace a drop of blood and know all the structures. And I know you all remembered it for an exam and you forgot it all. But in cardiac, you need to know where those valves are. Are they right side? Are they left side? Okay. So I'm going to trace one right here for you right now. So let's start where the blood just gets back to the heart. We know the left ventricle pumps, it goes out through the body and then through the vena cavas. It comes and drops into the right atrium. Pressure very low. Between the right atrium and right ventricle is the tricuspid valve. It goes up through the pulmonary valve into the lungs, comes back through the pulmonary veins and goes to the left atrium. Goes through the mitral valve, goes to the left ventricle, goes up the aortic valve, up the aortic arch, into the body. Now, What happens if that blood coming out of that left ventricle up the aortic arch into the body is narrowed? It's kinked. And blood can't go there. That left ventricle is trying really hard, right? So, blood can't go down. How would you know that? One of the things we do on all newborn babies is check all the pulses, right? So you check dorsalis pedis, you check posterior tibial, and you don't feel a pulse. Hmm, what am I going to do next? Knowing there's no pulses in the lower extremity, because remember, the aorta is kinked. That's the main hose that feeds the lower body and all the organs. Well, I'm going to do a 4 extremity blood pressure because if the blood's not going down, those lower extremities on the legs, blood pressures are going to be at least 20 millimeters mercury less than the upper because blood flow then will go up. You notice those 3 little hoses that come off the aortic arch, right? They go up to the carotid, to the upper body, goes to the arms. Those blood pressures are going to be 20 millimeters higher. So you're going to have this discrepancy. Sometimes this is not caught right at birth. There's enough flow going to the legs, they don't feel it. You still have those pulses, you still have capillary refill, and it's later on in life. These kids, because of all the blood flow going up top, have headaches and get nosebleeds, and that's how they diagnose it. So, did you see the kink in the hose and what happened? Well, what else happens with a kink? Well, blood can't go down, although what it can went up, but it goes back into the left ventricle, up to the left atrium, and it goes back into the lungs and it fills up. And these are the coarctations that we find at 3 and 6 months with congestive failure because blood can't go down to the body because it's been kinked. Because the blood has to go somewhere, right? So, one little girl I took care of became one of my favorite little things, was 3 months old. This is exactly what happened to her. And she was in an area where they didn't know pediatric cardiac stuff all that well. So finally, she got to us from the other side of the state, came over to our hospital in Miami. And all of these symptoms is what she had. She couldn't feed, she was tired, she got tachypnic, tachycardic, she wasn't getting nutrition, she was weight was very low, failure to thrive. She couldn't even finish her bottle, she was so tired. Activity intolerance. She's not getting nutrition. So those, cognitive delays, developmental delays were definitely there. I mean, sometimes we know because something's going on, there's a history, but many times we don't. One of the nursing diagnoses that you could use for this child with poor weight gain is inadequate oxygen perfusion. It's the coarctation's not getting what it needs, filling up the lungs. There's not enough space for oxygen to perfuse, leading to activity intolerance, resulting in diminished energy to breastfeed. And that's why you have poor weight gain. So in cardiac kids, we look at them. Now, they're not all cyanotic. There are many acyanotic, fully oxygenated children with cardiac problems. So it's not always color. We are going to measure as we go along, and not at birth, but month or two down the line, nutritional status. We're going to look at chest deformities. I mean, it got to the point where I could put a hand on a chest and I could feel murmurs, something that wasn't right. And it does, it buzzes on your fingers actually. And then as they get older, you might see clubbing, and I've got a picture as we go. You do your palpation, your percussion, looking at the chest, the abdomen, looking for those pulses, like I said, right? And always you look at the heart rate. Is it, 140 to 160 is normal? Well, we're at 180. Something's going on here. And then you also see the respiratory rate elevated. Something is obstructing. So we need to look further. So every child gets put on, the leads to the monitor, and we do a 12 lead EKG. We look at it. I mean, you can see hypertrophies in that and dysrhythmias. Well, we're going to do an echocardiogram. And an echocardiogram will begin the investigation. What's going on with that kid? So looking at, it's like an ultrasound when you look at your babies, intrautero. And that echo looks at the heart and the chambers and blood flow. If you find that there's something wrong on the echo, definitely prepare the family. They're going for a cardiac cath. And the cardiac cath is your definitive diagnosis and gets that surgeon the information they need in order to do the surgery that's the best for that child. And that's diagnostic. Interventional could be you're born and your aortic valve is narrow. They could go in and they could, balloon it and open it. And that's an interventional. Sometimes they have to go in on one of the conditions, and that little hole that you're born with between the upper chambers, that foramen ovale, they open it a little more to let blood flow for other reasons. And then there's what we call EP studies, electrophysiology studies. Children do have dysrhythmias. Usually, an EP study is for those tachydysrhythmias. And we know we've learned the pacemaker of the heart is in the right atrium and it keeps the heart rate where it should be. Well, who's to say that somewhere else in that right atrium says, hey, I want my turn? And the normal heart rate of the atrium is over 200. Okay. That's the normal one, not the pacemaker, but everywhere else. So what happens is this other foci, as we call it, beats periodically and elevates the heart rate to 240. Then it goes back to normal and 240 and down. And we'll treat them with medications at first, but when they get old enough, we will take them to cardiac cath, do an interventional electrophysiology study. We will find out where is that little person in that right atrium making a mess and beating too much and zap them with a laser. And we stop those tachydysrhythmias. As simple as that. So what do we do for cardiac caths? I mean, nursing responsibilities. Well, in a cardiac cath, they go up the right femoral vein and the right femoral artery. And they shoot dyes and they look at it. I mean, there usually is no sort of, infection problems. There's no problems with dyes and allergies and all of that. Our biggest risk in a cardiac cath is when we're all done and those catheters are out and then they start bleeding again after we've stopped that bleeding. They can bleed out a lot really, really quick. So you get the kid back from a cardiac cath. Number one thing you're going to do is check that dressing in the right groin. That some older kids will have a sandbag on it. It is very, very important. If they're bleeding, a little infant can bleed out their blood volume very quickly because those holes are huge as in comparison to that little infant, okay? You'll definitely check pulses. You'll document what you felt. It's going to be slightly decreased on the right. That's normal. We're going to look at vital signs always, making sure they either have an IV or they're going to do PO fluids. And we'll always check a blood glucose. Sometimes they're not getting any sort of sugar in procedure, and especially the younger kids, they can come back hypoglycemic. So you're saying congenital heart defects. Are there a lot? Well, when I opened the cardiac unit, I didn't think there was that many cardiac kids. And then I found out There are quite a few of them. Is the major cause of death in the first year of life after prematurity. It's getting a lot better with all the advancement, but still, there's way to go. Most common of all the congenital defects is what we call a VSD, or a hole in the septum between the two ventricles, ventricular septal defect. Down's children, like I said last week, are very apt to have a cardiac condition, a minimum of a VSD. Rarely do you have a Downs kid who doesn't have anything. So as I said, there's cyanotic and then there's acyanotic. And it just depends, is blood getting to the lungs and getting to the body? I mean, holes don't make it that there's no blood flow. I mean, you can have a VSD, ASD, and blood still flowing around. You're only having extra blood going back to the lungs because you have a hole there and you have oxygenated blood going back to the right side and back to the lungs. And, just extra flow there. Now, shunting, like I just said, when blood comes back to the heart, it just gets to the right side, right? And then you have the left side getting really powerful blood from, actually, there's 4 pulmonary veins. I never knew that. There's 4 feeding blood into the left atrium. And if there's a hole between those sides, it's going to go from area of greatest resistance to least resistant. It's going to push over. It goes back into the right ventricle and back to the lungs. And that shunting from biggest to less resistance, it just goes like mucus in the neck up into the ears, areas of least resistant. So this is from your book, picture. So we have ASD, VSD. I just told you why there's increased pulmonary blood flow. And there's something called a patent ductus arteriosus. This is fetal circulation. This is that connection between lungs and the body. So pulmonary artery to the aorta. There's a shunt. Now, the thing about this shunt is mommy secretes a hormone called prostaglandins, and it keeps that shunt open. And when mommy delivers the baby, mommy's not there anymore with these prostaglandins, and usually the shunt will by itself close. Now, sometimes we need that in order to oxygenate the baby. We can give synthetic prostaglandins in a very slow, continuous IV infusion. So PDA is an important concept. It's the prostaglandins that keeps it open, all right? And we can administer them. And I'm going to go further and tell you if we need to close it in a couple more slides. All right, we've learned about obstruction with a coarctation, and it's that backward stuff that we worry about into the lungs. When you see something with an osis on the end, OSIS, it's a narrowing. So blood is still going, but it's narrowed. When you see an atresia, A is without. That means there is no connection. Not even a drop. There's no connection. So, aortic stenosis, pulmonic stenosis. I mean, we usually treat that by ballooning it in the cath lab if it's good enough to be able to do that too. Know that aortic is left side and pulmonic is right side. Always think of that. Tetralogy of Fallot is the most tested of all of your conditions. The most. Ever hear of a TET spell, the blue baby spell? Well, this is what it is. And it's the pulmonary artery kink spasm. Something goes over the pulmonary artery and blood can't go to the lungs. I had one TET spell on my watch. Little Nolan was a newborn with tetralogy, and I was changing his diaper, maybe cleaning his face or something. He went into a TET spell. He was at 100% oxygen is when I started. He went into a spell, and in 2 minutes or less, it seemed like quick, he went to O2 saturations of 10. From 100, he went to 10. He turned blue. So what do you do for that? You take the knees and you pull it up and push it to the chest. The kid was on the side, so I push him on the side, okay? Why? Doing that forces the abdominal cavity to force pressure on the chest cavity, and the change in pressure usually pops it open and lets the blood flow. And it worked with Nolan. Tricuspid atresia. Well, where is a tricuspid valve? It's on the right side between the right atrium and right ventricle. This means there's no opening from the right atrium to the lungs. This is one that's going to need that patent ductus arteriosus open to oxygenate that baby till we fix it. And then we have the other cyanotic transposition of great arteries. TGA is another name. And what it is the aorta and the pulmonary artery are switched. So you have oxygenated blood going around and you have systemic blood going around, and they're not meeting each other. So this child's not getting oxygenated. So guess what? They need open to live. A patent ductus arteriosus. They'll be put on prostaglandins to keep it open. And the other one I'll mention is the hypoplastic left heart, the most severe of all the cardiac conditions. It is a 3-stage surgery. Many of them end up with a transplant. Their hearts are so weak. The left ventricle is thickened and it doesn't pump. And these children are born and their O2 saturations are 65 to 75%. And you don't want it much higher than that. So very severe. Okay, patent ductus arteriosus goes from pulmonary artery, so you have pulmonic oxygen, go into the aorta, which is going systemic. It gives a connection to allow oxygen to go there. Now, when you see it, I mean, usually at birth, they're there. Because remember, mommy keeps them open. And after birth, they say up to 21 days it's open. Usually it's in like 2 days, I see them closed. And how do I know that? Well, number one, there's this loud washing machine murmur that you will hear. And as it closes, many of these children are cardiac and they're on monitors and they have umbilical lines, arterial lines, and we can watch their blood pressures. And at birth, these blood pressures is what we call a wide pulse pressure. So 60/40 is a normal for a new neonate, right? You might see 60 as your systolic, but instead of 40, you might see 18, 16. The bottom number is really low. And as it closes, the number will come back up closer to 60/40. And if we do a medical treatment of it, which we give indomethacin, we can close it. There are cases, and it's usually your premature infants, some, full-term children, but usually the majority is a premature, and it keeps open, and it just keeps going and over rushes the lungs, so we need to close it. So instead of doing surgery, we can give a medicine and it's called indomethacin. And we can watch the pulse pressure close. We can watch the murmur stop. And those are things we know it has happened. So prostaglandins, keep it open. It maintains cardiac output and oxygen saturation levels, which we want that. Indomethacin closes it because we don't need it. And then if that doesn't work, they can do surgery and close it. These are some things I've already discussed. I've left the pictures there for you. And now we're going to congestive heart failure. Well, I just showed you one way congestive heart failure can occur, right? Coarctation. There's a kink, it doesn't go, blood goes back up into the lungs, and now the heart is floppy, it's not beating well, and you're in congestive heart failure. What do you see? Well, the lungs are going to be full of fluids, right? So the heart's not beating good, you're not oxygenating well, these kids are tiring out, they're not getting nutrition. What do we need to do? Well, we want the heart to beat better. We want it to squeeze. We want to get this fluid out of them. We're going to be giving them a furosemide, a diuretic. And we do give the adult dose, we'll give 0.1 milligrams per kilogram, and that's of your furosemide. And we'll also be giving digoxin to slower and strengthen that force of contraction. And fluids are going to be going away. So the heart demands are less, and now we're getting oxygenated. Now, if we're going to be giving digoxin to an infant, we're not going to know all the signs and symptoms that you would see with an adult. I mean, adult will tell you they see yellow spots, right? An infant can't tell you that. How do we give digoxin? Well, exactly like adults. We're going to count an apical pulse for 1 minute. We're going to make sure the potassium is a normal level. We're going to check the last digoxin level. And in infants, if they're vomiting, we are not giving it. That's sometimes the only clue. They might have a heart rate that's acceptable, but they're vomiting. Call the doctor, and we're going to do a digoxin level to be sure, right? So, how do we know that digoxin's working, furosemide's working, and the kid's improving? Well, we're going to see that weight loss. That's why we do daily weights on these children. We're going to be strict intake and output on these children, making sure we're getting rid of that extra fluid. Now, that hypoplastic left heart, I told you O2 sat 60, 65 to 75, right? What does the body do? Well, the body says, well, you don't have enough oxygen. So I'm going to make red blood cells because red blood cells carry oxygen, right? So the body keeps producing and producing and producing, and you get to the point where you're polycythemic. You could have, and this is not uncommon for like this cyanotic congenital defect, a hypoplastic left heart, you might see a child with a hemoglobin of 18 and 54, 19 and 57, not uncommon. It's dark, it's black, it's thick. It's just part of it, okay? And this is a picture of the clubbing of an older child, most likely one of those hypoplastic left hearts. Now, cardiac families are unique. They're mostly the most wonderful people you'll ever meet. These people are thirsty to understand and learn about their child so that when they take them home, they feel comfortable. So help them adjust to it. As soon as I can, I put these infants in parents' arms. I mean, they're intubated, they got IV lines, whatever. These parents need that bonding, and I do that for them if the child will tolerate it. You know, you're going to tell them how to educate at home. You're going to teach them what you're doing. Why are you weighing them? Why are you listening to lungs? Why are you listening to breath sounds and heart rates and pulses? Why are we doing all this? And as I'm doing stuff to these children, I'm always talking so the parents hear me. So cardiac cath, I've already gotten over it and what to do. I think the only thing I didn't say is they are on bed rest for 24 hours, and that right leg where those catheters were, you need to keep it straight. You don't want that clot to dislodge so that this child will bleed everywhere, okay? And if you're elevating the head of the bed because they need to drink, go slowly. Bacterial endocarditis. This is an infection that we treat prophylactically before procedures, before dental, before casts, anything that we're going into the body, they do need treatment. Now, strep throat is benign, right? No, it's not. Strep throat, if we don't treat it completely and get rid of the strep, there can be residual in the body and it can cause rheumatic fever. Rheumatic fever, you're going to see swollen joints, you're going to see rash, you're going to see this, what we call chorea, these movements and uncontrollable of the extremities. And the worst of all, you're going to see it affect heart valves. This is that mitral valve that they like to attack. And we can treat all of it with antibiotics. They didn't treat the strep the first time. We're going to be treating it a long-term antibiotic, and everything will be corrected except if there's heart valve damage that will never, never come back. So get a kid in showing these symptoms. Has your kid been sick lately? Has they have a sore throat? And it's going to be positive, and it's because they had strep. Hyperlipidemia, we didn't always test for this in young kids. We never thought they had it, but we're finding out they do. Cardiac dysrhythmias, like I said, they have all different things. Brady dysrhythmias. I think the youngest child that I saw with a permanent pacer in was 1.5 or 2 years old. He had Brady dysrhythmias and he had to have a pacemaker. And yes, they do it that young. Pulmonary artery hypertension. Somehow all this extra flow's gone to the lungs. The lungs say, oh, I don't think so. They tighten up and stiffen. And then what happens is a permanent disorder where you can't exchange oxygen and carbon dioxide. And because you have a decreased oxygen supply, definitely dyspnea with exercise, and even minimal, that causes chest pain and syncopes due to less oxygen on you. And they do have different things that they do if they are that really severe. They have continuous infusions, like an insulin pump. They wear a different sort of medicine. I've also seen Viagra used for pulmonary artery hypertension. It dilates it and allows it to flow. So, and usually pulmonary artery hypertension is going to lead to a lung transplant if it's severe. Cardiomyopathy, didn't I tell you this is a lot of times we'll see a viral infection cause it. And the heart gets big and it gets floppy and it doesn't work well. These children usually they get really dyspneic and congestive failure. They come in and get what we call a tune-up. And we get rid of the fluid and get the heart working the best we can. And it comes to the point where it doesn't work anymore and these kids go for a transplant. What is the biggest reason for death on a transplant? It's rejection. It is not infection, it's rejection. And these kids, they'll have all different signs and symptoms that. Kids who have open heart surgery are going to wake up and they're going to have chest tubes, 1 or 5, all different depending on the surgery. Now, one of the things that I've been saying is if you have a child doing a procedure that's going to hurt, be honest. Now, I have worked in adult open heart and in pediatric open heart. I worked night shift, and 6 a.m. was the time all the residents and fellows love to come in on the adult ward and pull out chest tubes. So I've seen a few. It burns. These patients tell me it hurts, it burns, but it's quick and then it's gone. Now, how are you going to take care of this kid? I mean, we're atraumatic care, right? We try to do as least as possible. make sure we medicate for pain before we pull out these chest tubes. And remember, whenever you use any sort of pain medicine, you always need vital signs before and after. That is a given. Explain to that child on their level what's going to happen. I would say, hold my hand. Let's count to 20. It's going to hurt, but I'll be here with you. I'll make it as least as we possibly can. But at least then the tube is gone. And then we get you out of bed or whatever. Give them something to look forward to. But always be honest. Children do get blood pressure, elevated blood pressures. It was a new thing, 15 years ago. Children coming in, we never checked, blood pressures on the younger kids, less than 5. Well, we found out many of these kids have hypertension, and we know that high blood pressure causes a lot of damage. I mean, think about the kidneys, number one. I mean, causes a lot of problems. Kawasaki disease, the reason why it's here in the cardiac area is because it causes systemic vascularitis and could cause coronary artery aneurysms. Can you imagine a coronary artery with an aneurysm that bursts? That is scary, isn't it? And what this is a viral disease. These kids have had a fever, not feeling good, maybe a little rash on them initially, and then later on, red glow in the dark eyes. I mean, it's very distinctive. Red lips, strawberry tongue, swollen lymph nodes. And then the other thing, sometimes all of those you don't see, but you'll see a little peeling or blistering of the palms of the hands and the soles of the feet. And it's Kawasaki. We usually have to call infection control physicians down to diagnose this. Used to be one of those things I used to have fun diagnosing. I'm like, oh, it's Kawasaki. Look what I see. I'm like, yeah, you're right. But that's what I did. Now, how do we treat it? Well, it's a virus. So we need to boost that immune system. So we're going to be given IVIG. And the other thing, like no other diagnosis, we give high dose aspirin. Why do we give aspirin to a child with vascularitis? Well, they have microembolus, and we want to prevent clots. Okay. Shock can happen to any child. Most of the time, shock in children is septic. Remember, shock is elevated heart rate, decreased blood pressure. It's going to be poor urinary output, poor capillary refill, poor perfusion. All of these things you're going to see in shock. So, surgical closure of that patent ductus arteriosus would do what? Remember, this is the tube that connects the lungs, pulmonary artery, to the aorta. So if we cut that off, what's going to happen? Anybody want to guess? There's your answer. Prevents that oxygenated blood to go back to the lungs, and it keeps it in the body where we want it to be. So, any questions? A lot of information. Okay. Lungs, heart, they work together. I hope I made it a little simpler for you, that at least now you go back and look at it, you can, remember those key things. Anybody want to win a Kahoot today? I'm going to go as far as I can with it. There's 59 questions. We'll just talk really quick tonight, right? right, let's get going. And let's see how we do today. Week 5. We're almost halfway through. 3, 2, 1. A majority of upper respiratory infections are caused by what? It's viruses. Very good. Yes, it is. You walk into a 6-year-old child's room and you find them not breathing and doesn't wake up. What are you going to do? It's the first thing you do. Again, I told you, go back and look at your CPR. There are sporadic questions regarding it, whether it's the parents' involvement or what we do for choking children or CPR. And it's number 1, you go right to the chest compressions. They don't do breaths first anymore. You have enough oxygen in your body residually. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? So it's more than one. It's all the above. Most of the kids who have any sort of sickness with a fever, they're going to sit in the corner. They might vomit. They're not going to eat. Us as adults will eat all the time. Kids, they don't feel well, they stop. And you want them to drink their fluids, so medicate them. Another multi. What do you look for when assessing respiratory function? Again, a little bit of everything. And in children, I look first. You can see retractions between the clavicles. If it's pulling hard, you know you're in trouble. Infants, you'll see their noses flaring. That's a big thing. And also in infants, when you're doing respiratory, at the end of a breath, if they grunt or go, uh, uh, after each breath, that child's about to code on you. So be aware. What would you look for after a child that has had a tonsillectomy? What's a concern here? They've gone back and they have just cut off these things and they've cauterized and put scabs in the back of the throat. What is a big, big concern here? And it's bleeding. How do we know they're bleeding? They're swallowing. And don't ever open their mouth, put tongue depressors in this child because it will create even more. But they're swallowing, just have them stick their tongue out a little, and I'm sure there's blood on it. Another multi. There's a lot on this one. Nursing care for a child status post tonsillectomy include. What are you going to teach parents? Because these kids, 99% go home. So no spicy foods, no citrus. We don't want to irritate it, but give them their pain medicines. And Tylenol works well on these children. Gum to chew to help their ears on the older children. And then if they'll tolerate it, an ice bag. Another multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Which is that one? Something you need to remember. And there's all sorts of respiratory conditions. And that's tracheobronchitis or bronchitis, and it's also known as an inspiratory stridor or expiratory stridor. Asthma, you get air in, but it's swollen down below, traps it, and you can't get it out. So expiratory wheezing. Bronchitis, croup, you can't get it in. So those two things will give you clues to your diagnosis. Another multi. What signs and symptoms would you see in a child with otitis media? So otitis media doesn't always have fevers. That's what's crazy about the ears. But they're gonna have ear pain, and that's your priority to treat when you get that child, into the doctor's office or urgent care, whatever. Because antibiotics isn't your priority right now. You want to stop that pain. The antibiotics will kick in a day or two. I mean, I've over Christmas I had pleural and ear drainage coming out of one of my ear. And remember, kids sick always lose their appetite. Adults, no. Kids, yes. What is the monthly immunizations for RSV? And that's Synagis. That's Pavizumab. Humira is for rheumatoid arthritis. Okay. It's Synagis. Don't forget that one. You're going to see it again and again. All the following are signs of early respiratory distress in children, except look at that picture up there. Do you see that big concave? That is what we call retractions, isn't it? That kid is sick. And I'm sure they're flaring and grunting at the same time. If your kid is in respiratory distress, is now bradycardic, be prepared to code the child. That kid is going to code. A 4-year-old child has been taking meds for asthma and they're still wheezing. What information is important to ask? You need to be this little, detective here. All right, you're taking your medicine. They're still wheezing. Like, why? And remember, a 4-year-old, can they push the button and inhale at the same time, right? So we use that little plastic thing, spacer, and we get what 1 or 2 puffs, whatever it is, the dose, let them take it in and out. Even younger children crying is actually best because they take deep breaths in, right? And they really get that medicine. So younger kids will cry. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Croup, inspiratory stridor. That is your upper airway. And remember, croup turns into epiglottitis if you don't treat it. And we treat it with what? Humidified air and steroids. So, what are those things? Retractions, and then restless, we're getting hypoxic. Signs and symptoms of asthma include all except my husband had status asthmaticus in the ICU for 12 days straight. And I'll never forget it. It was, he tried to breathe out, nothing happened. And then when his lungs opened a little bit, when he breathed out, after a little bit, you heard a in the lungs, and that was it. It's prolonged. You're pushing that air out. Get it in good, but you can't get it out. That is prolonged, not a short one. They're coughing, they're wheezing, they're short of breath, or all the above, but it's prolonged expiratory. Signs and symptoms of congenital heart disease include all except what? What is not appropriate here, right? All of those are congenital heart disease. Remember, you have a heart that's not beating right, blood's not flowing the way it should. What do you expect? You expect weight loss, right? You don't expect weight gain, and all of the rest, yes. What should you not do to children diagnosed with croup and epiglottitis? Remember, croup and epiglottitis has to do with the epiglottis and the upper airway and swelling. It's all inspiratory stuff. You leave that throat alone. Remember, this epiglottitis is the one that you need to have a trach or intubation tray or both at the bedside. That is what you as a nurse should put there. The epiglottis is what? What is that thing? That's the thing that creates havoc with epiglottitis, right? It's a leaf-like structure that covers the larynx so that you can swallow so you don't choke. Another multi. Treatment for infectious mononucleosis, the kissing disease. That's benign, right? No, it's not. Remember that there are swelling of the lymph nodes, liver, and spleen with it. So that is the biggest concern. Infectious mononucleosis is a virus. It's an Epstein-Barr virus. No antibiotics, all right? Tylenol, Motrin, rest, liquids, and protect the belly, no sports. Another multi. When doing an admission on an infant with a low-grade fever and loose cough, what information is important to know? You're doing an admission history. What do you need to know? What is important? APGARs, it doesn't matter. I want to know what fevers have you had, immunization status, absolutely. And then I want to know when you've given your Tylenol or Motrin if you can, so I can give some more. What is cystic fibrosis? It's where you go blind in one eye, right? No. It is two systems. It's the lungs and small intestines. It's all this mucus, and you have two things you need to take care of: the lungs and nutrition. What is the greatest risk for an infant having a cardiac catheterization? I have no clue how they can take these little children at 4 and 5 pounds, do cardiac catheterizations, and it's just mind-boggling to me, and I've watched it for years. It's all about when they come back, number one, check the dressing because you're worried about hemorrhage. That's your biggest risk. How is cystic fibrosis identified? Besides not having a stool at birth, makes you go look for it, be a detective, right? But how do we say, yes, this is what it is? And it's that sweat test. And the metabolic screenings can also show it, but the sweat test. And it measures salt on the skin. A multi. What is included in the plan of care for a child with cystic fibrosis? We know it's a two-system diagnosis, so we need to be concerned about both. They're both as important. So why do you want to do low sodium on a child who is sweating salt out of their pores? Never, ever restrict the salt on a child with cystic fibrosis. They need it. They're losing it. Chest PT, you want the nutrition with the enzymes, and high protein is always because they're not getting other nutrition. Protein is the other thing that you can give that's good. So, what is the drug of choice for a pharmacologic closure of your PDA? I put all the good medicines here to see if you can pick it. So prostaglandins keeps it open, indomethacin closes it. Synagest is for RSV. Very good. What is not a feature of tetralogy of Fallot? No, I didn't teach you this, but it's all on the right side of the heart. Remember, it is that pulmonary artery that has a flap, and that right ventricle gets swollen. And usually there is a hole between the bottom chambers, and the aorta sort of pulls over. Those are the four things. Now, what is not? Well, the aortic valve is on the left side. All right? So everything else it would be. What medication would you hold on an infant that is vomiting and the vital signs are 98, 88, 32? What's very, very tricky about giving medications to children is you need to know normal vital signs, normal blood pressures. And it's something, if you don't know, ask someone or look it up. Nobody knows everything at first. And this is all about digoxin. If I saw a heart rate of 88, I'm going to hold it. I'm going to call the doctor. And he's probably going to order a dig level, which is fine with me. Why would a child with tetralogy of Fallot not gain weight at the normal rate? A child with a congenital heart defect. It's because they have no energy, because they have no oxygen, so they don't eat. Very good. Good job on that one. That's a hard concept. Multi. All are examples of a cyanotic heart murmur except. Try to figure it out. And actually, I want you to know there are two here. So a little narrowing is not going to decrease blood flow, especially aortic. So an aortic stenosis, yes. Now, ASD, and I'm really proud of you guys here because the left side, the atrium goes to the right side and it just reflows. So your oxygen saturations are good. Tricuspid atresia, nothing goes to the lungs. And tetralogy is the most common of all cyanotic heart defects. Oop, what's the most common one? I just told you the answer. Most common cyanotic congenital heart defect. And that's your tetralogy of Fallot. PDA is not cyanotic. Truncus is not cyanotic. And thank goodness it's not the hypoplast. It's a horrible disease. Nursing care following a cardiac catheterization. I mean, we know what number one is. So, number one, check that site, right? Check the pulse. Keep that leg straight. 24 hours, keep them down. Check their blood sugars, give them fluids, elevate their head slowly. multi. Nursing education for cardiac catheterization include all except. So this child is not going to be ambulating for 24 hours, and they're not going to be bending that extremity because we do not want that to bleed. And we're going to keep that pressure dressing on, and older kids get a sandbag. Which information is most important when rheumatic fever is suspected? How do we get rheumatic fever? This is all about strep throat that wasn't treated. When we get to GU, there is another thing that strep can cause problems with too. Signs of shock in children include all of the following except shock. What do you see? All of it except what? I mean, whether you're a child, whether you're an adult, doesn't matter. All the signs of shock are all the same, and they're hypotensive, decreased urinary output, prolonged capillary refill, elevated heart rate, decreased blood pressure, altered mental status, all of that. Which of the following best describes the pathophysiology of Kawasaki disease? I love those red eyes. What was neat? Well, not neat. It was the director, the physician over the cardiac ICU's son at age 3 had Kawasaki disease. And that was the first time I had seen it. And he had those glowing in the dark red eyes, something I'll never affect. It affects the vasculature and it causes little microembolus. And we're worried about a coronary aneurysm. We treat it with its virus. We treat it with IVIG and aspirin, and the aspirin is to prevent clots. Big deal is clots with that vascularitis. Multi. Clinical manifestation of Kawasaki is, what do you see? We see all of the above. Chorea is rheumatoid, a rheumatic fever, okay? All the above. What is the treatment for Kawasaki's disease? One of the HESI questions that students came to me several years ago was, why do you give aspirin to a child with Kawasaki? And of course, it is to prevent clots. That's why that question got there. Which of the following is the most common cause of shock in infants and children? There's all things we can do. Many things cause shock, but what's the most common? And it's infection. Cardiac failure? No. I mean, yes, we're in the cardiac land right now, but it's infection. Infection, overwhelming. They can't handle it. They don't have immune systems. Yes, shock. What are the defects associated with tetralogy of Fallot? Remember, right-sided. Pick it out. Pretty good. Yes, you have a narrowing of the pulmonary artery. You have a hole between the chambers. The aorta sort of pushes over And when the blood can't go up, it stretches out that right ventricle, and that's right, why the right ventricular hypertrophy. A young child with tetralogy of Fallot may assume which position naturally when having a tet spell. Not all children, infants that have tetralogy are, have surgery when they're young. Some of them are older. And it's pretty neat that these kids just go to this, they drop to their knees. But what does it do? It does a knee chest, right? It changes the abdominal and the chest cavity and it makes it work. It's just a natural thing for them. Transposition of the great arteries, TGA. What is it? All I can tell you is that two blood systems, oxygen and systemic, they're not meeting each other. There's no oxygen there. Excellent job. I think this is the first class that had this question completely correct. Pulmonary artery and aorta are switched. Yes. Which of the following is not an intervention indicated for transposition of great arteries? Remember, this is a real serious condition. And they need to get blood flowing. They need to have oxygen get into the body because right now they're not at all. So we know that oral anything is not working quick enough. Now, arterial switch is the name of the surgery where they pull it off, turn it around, and put it back on. That's the name of the surgery. And then what they do is that patent foraminal valley between the right and left atrium, they go in cardiac cath. They balloon it, make it bigger to get the right and the left side exchanging oxygen and open the PDA. And that buys time for surgery with these cases. A multi. Why is prostaglandins given to a child with transposition of the great arteries? What does prostaglandins do? So oxygen is always number one, but it keeps the heart going. It is not an antibiotic. So endocarditis infections, no. All it does is open up that PDA and get oxygen and output. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? What is indomethacin used for? So you sort of have to understand the concept of what a PDA is. How are PDAs opened? We know that prostaglandins keep it open. So indomethacin stops prostaglandins from being made for whatever, and then it will close it up. Okay? Where is the PDA? Did it again to you. The reason why I have two questions is most classes don't get it right the first time. And it is an important concept. And it's the vessel that connects the aorta to the pulmonary artery. Again, it's a fetal circulation. This heart defect allows blood to pass from the left ventricle to the right ventricle. What's it called? There's a hole in the heart from the right to the left side. What is that called? A ventricular septal defect. In between ventricles or atrium is a septum, which holds the blood from the right to the left from going back and forth. When there's a hole, whether the atrium or septum, it's an atrial septal defect or a ventricular septal defect. Another multi. What is a sign of digoxin toxicity in infants? What are they going to show you? And I'm telling you, very, very common drug in congenital heart defects. Oh, somebody did say seeing yellow spots. How do you know an infant seeing yellow spots? You don't. It's that nausea, that retching, not eating, that vomiting, the low heart rate. That's what you see. What is congestive heart failure? It's when the heart doesn't work well and then fluid goes up into the lungs. Could be due to a kink or just the heart's given up. Left-sided congestive heart failure causes. This is what the coarctation of the aorta causes. Left-sided. Can't go down. So it's back to the left side. And the heart fails. It's tired of pumping against this stricture. And it's fluid in the lungs, shortness of breath, coughing. Very good. After a heart transplant, what's the leading reason children die? And it is rejection. Very good. A multi. Signs and symptoms of rheumatic fever include, remember, stewed from a strep infection. So you might see the respiratory distress, polyarthritis, chorea. Those joints are swollen. Remember, there is valve involvement in the heart. Everything can be stopped except for the heart damage. A multi. A child is about to have a chest tube removed. What should you do? Always explain it. Always medicate them with pain medicine before. Be honest. Tell them it's going to hurt. And you're going to have them sitting up, not just supine. They need to breathe when it's done. A child just had abdominal surgery cannot cough well enough to expectorate secretions. What is your priority? Why cannot they not cough? I mean, pulmonary care is always important post-op. It's probably they're in pain. Any child in pain that you want to get up, cough, any, incentive spirometry, any of that, make sure that they're medicated because if they hurt, they will not. And then you're going to end up with pulmonary complications. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? Six months and less is only acetaminophen. At 6 months, you can add ibuprofen. Has to do with platelet coagulopathy and bleeding in infants. A newborn infant is assessed and you find very weak lower extremity pulses. What should she do next? So those pulses are not what they should be. What do you suspect and what should you do? This is the one that's probably a coarctation. So it's that 4 extremity blood pressure. Very good. A multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? Critically ill children, adults, complete bed rest. There's so many things that can occur. You have respiratory, you have, a thrombus, you have bed sores, foot drops. All that happens with children too. So, what are we going to do? Well, keep the lungs going, keep them dry, use pillows, blankets, position them, elevate the head of the bed. Maybe, maybe not. The other ones is what you needed to do. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? This is something from last week. I always throw a couple in. And that's your oxy hood. Again, you can say exactly how much oxygen's there. The kid can look and play, and you can have a pacifier. It is better than any other. And a multi. What procedure are used to keep lungs open with a child with cystic fibrosis? Remember, their lungs are like these big, thick petri dishes, and we really need to keep them loose, and we really need to keep those lungs moving, don't we? And with that being said, what do we have to do? We need to do everything, but we don't want to ambulate PRN. We want to ambulate TID, QID. It is not when we want to, it needs to be more routine. A multi. Child with cystic fibrosis requires pancreatic enzymes with meals. What teaching should be done? Remember, the pancreas doesn't work the way it should. We need to do something to help with nutrition here. So we give it before meals and snacks. You can sprinkle it on a little food. And then please make sure that doses change as they get older. And any powder they put in, they're going to have to, rinse their mouths out because it can hurt their teeth. What is the cardiac defect where there's no valve between the right atrium and the right ventricle? Again, you need to go back and look at the heart. Look at the anatomy. Sometimes just knowing the anatomy, you can figure some of these questions out. And it's called tricuspid atresia. Why? What is the valve between the right atrium and the right ventricle? It's a tricuspid valve. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? Like what do you think could possibly be going on? Probably we're going into failure. So always the breath sounds with that one, just to be sure. See how we did today. Sarah, good job, Sarah. Number 2, Sierra. Good job, Sierra. Number 1, Alicia. 4, Alexis and Anna. I mean, this was a really, really hard week. A lot of concepts that you don't see, not even in your med-surg adult. So it's a lot of new learning for you. So I know it was hard. Anybody who needs extra help with it, let me know. Anybody 78 or less on their exam, please make an appointment. If you got an 80, you want to know what you got wrong, make an appointment. I'll work with you and I'll let you know what you did wrong because I don't want you to go forward and not know. Okay? Thank you, everybody. I'll see you next week. I'll be starting reviews and getting ready for the exams. I'm working on the study guide right now to encompass, what might be on any exam. So I'm working hard on that for y'all.
Thank you.
See you guys.